Now we have the discussion part, so I would like to invite all the present presenters to come to the stage. And then we definitely want to engage you so you can ask your questions. We can have a discussion. We're going to discuss what is important in the future. What will be the research topics in the future? What will be the direction we are moving in the various topics that we have tried to cover in this symposium. And the good thing is that no one has the right answer. We don't know, so everyone can contribute. So I'm looking forward to hear if there's anyone having questions to these. Joel Gelfang, yeah.
Oh, it's on. Oh, yeah. First of all, this was a beautiful symposium. The talks are really terrific. I learned a lot, so thank you for organizing it. Hopefully there won't be too much feedback from the microphone. So I want to ask the panel about the use of Mendelian randomization and the interpretation of these studies, because this is what my concern is about the method, which is that the genetics of psoriasis have very poor predictive value of who actually goes on to have psoriasis, and virtually no predictive value of who has severe psoriasis. Can you hear it all? Okay. It's hard to hear from the stage, is my guess. I'm getting a lot of quizzical looks.
It's difficult to hear. Is that what you're saying?
It's on. It's on. But maybe you guys are getting a lot of feedback?
Yeah. Try again. It might be better now.
So the question is about Mendelian randomization techniques for psoriasis. And the issue, in my view, is that the GWAS is basically an instrumental variable for predicting psoriasis, but we know that's a very poor predictor. Statistically, in terms of p-values, it's good. In terms of predictive value, it's very weak. So you could estimate maybe 5% of the people who have a GWAS for psoriasis actually have psoriasis, and then people try to infer that, say, that GWAS of psoriasis predicts or doesn't predict obesity. So it's not entirely clear to me if we could conclude that people with psoriasis, the disease itself, doesn't somehow have a causal link to them becoming more overweight over time once they actually have the disease, had the exposure to it and ongoing inflammation. It's just not clear to me if the Mendelian randomization would answer that question. I'm curious of what your thoughts are on the topic.
I mean, Joel,
yeah, it works. Yeah.
Joel, I mean, I take your point entirely, and as I prefaced when I started talking about it, I did mention my ignorance about some of the issues around Mendelian randomization, and I'm well aware that in order to undertake the tests, various assumptions are made about the genetics, about the populations, about whether they're modifiable or not. So yes, it's not dichotomous, it's not black and white, but nevertheless, I think it's very potent evidence in terms of suggesting a direction of causality, but I do agree that it's not completely black and white.
Yeah, I mean, I guess I would caution people from saying that something doesn't cause something, okay, because you don't really have the statistical power to make that statement. And then on the flip side of it, I mean, ultimately, it's really the genes that are driving this, not necessarily the phenotype, because even with obesity, I don't know what the predictive value of obesity is, but you would have to sort of know that to really infer that causal association, because it could be the genetics itself or risk factors for psoriasis. You could have genetics that are related to obesity that tend to end up causing psoriasis, not obesity itself. It's possible.
Again, I agree with you. I mean, this is a study of the genetic components of both of those traits. There are clearly other things going on as well, yes.
So any other questions? Yeah, Eno.
Yeah, thank you. Well, first, I'd like to congratulate you with this excellent symposium, beautiful lectures. I have a question, a relatively simple question related to obesity. What's the causal relation between obesity and psoriasis? Do we know anything about this?
I don't know who wants to try to answer that.
Are you asking the biology from the obesity that's driving the psoriasis?
Because this is not just related to psoriasis, right? This is probably related to more inflammatory diseases.
Well, I guess that my thought on this is that adipose tissue has a lot of pro-inflammatory cytokines. And I think that it has to be in part what's going on. There's a lot of pro-inflammatory cytokines produced by adipose tissue. And if you deplete the adipose tissue, you don't have the pro-inflammatory cytokines.
I mean, from my part of the talk, there's actually a Dutch study from the post-famine in the Second World War that the population which were actually in the famine phase actually had much less inflammatory diseases than afterwards. What was actually also referenced in the paper by Elaine Fuchs and Schrotinuk is that you also have in this regard a memory and an inflammatory memory, and you get prone to these responses if you have a Western healthcare or food intake which is problematic with an increased risk of inflammatory diseases. So this might be this inflammatory memory plays a role in that regard as well.
Thank you.
So, any other questions? There's one down.
Thank you very much for a great session. I just have a question about epigenetic mechanisms of formation, that immune memory. And so you mentioned that the short disease duration predicts the better response. It means that if we start the treatment with the biologic therapy early as it possible, so we could prevent the formation of inflammatory memory. So does it mean that we must to avoid all other options of treatment of psoriasis, for example, methotrexate or others, even if we have...
I mean, that's a great question.
Okay.
And
yes.
It's also an ethical question in the end. I mean, we cannot treat everyone with biologic. It's just not affordable. That's what I said. I've written down a subpopulation or certain patient might benefit from this early intervention. We certainly have to identify patients which very quickly develop severe disease and maybe bypass all these treatment pathways that take then 6 years until they get onto an effective biologic treatment, while the other one which have some plaques on the elbows, we might not be the ones which actually need that. But for the ones which really have a very fast development of the disease, we might want to go very quickly to an effective biologic to actually decrease the pathway, and they might also actually come off the drug again in the future. So that's also disease modification. Doesn't mean you have to cure it, but you might actually be less dependent on the drug itself in the future.
Yeah, I mean, if I can just add to that, I mean, my view is that this is a systemic problem, and I think that the earlier you treat patients with systemics, probably biologics, the better, because even if they've got a PASI of 2, we know that the uninvolved skin is immunologically abnormal already. And so if you wait, there's no other diseases where you just wait until you've gone through all available options and then you go to something that works. Why not go straight in with something that you know is going to make a difference? And, that's slightly a heretical answer, but I think that's the way we should start thinking about this. And I think that the step-in study, guide studies, other studies looking at very early intervention in psoriasis will prove that to be a disease-modifying process. Is that the earlier you get in there, the better chance of having a long-term remission or even cure.
And is it the same logic when we treated the child under the 12 years old, for example?
Yeah, I mean, at least for me as well. I mean, generally, you have a tendency to quicker go to biologic, and again, you might, this is a patient who then eventually would need to be on a drug for 50, 60 years. So again, if you can change the disease course in such a patient, that would be amazing. So yes, we have a tendency to be quicker on a biologic in these kind of patients.
Thank you very much.
I think it's extremely important that we become very ambitious as dermatologists, and we have, of course, the opportunities in the systemic therapies, that new systemic therapies are available with outstanding safety profiles, but also in the field of topicals. There are developments in topical treatments that we also can become more effective. And for me, it remains often a question at what moment indeed to move to the systemics. And I agree that we should in principle also consider psoriasis as a systemic disease, and also in our monitoring of the efficacy, not exclusively look at the skin, but actually also consider us as responsible for monitoring more than skin deep.
Thank you. Could you please identify yourself? I don't see, yeah, down there.
Yes, thank you. Very nice talks to start with. I have a question to the memory and the role of T cells, and how you would interpret the data from this recent PAUSE trial that used abatacept after ustekinumab and which was negative. Would you think that maybe the signal 2 is not necessary for the T cell activation, or similar to the Naik and Fuchs story where maybe the chromatin remains open? Or do you think the TRMs might not really play that big of a role?
I apologize, I didn't understand the first part of your question, but for the second one, I do think the TRMs are absolutely critical. That's without a question. The question is, if we treat early on, what do we actually change? Do we change the epigenetic changes, or do we actually prevent the TRMs to develop a major memory in bigger parts of the skin? This we don't know. This needs to be addressed in these studies, but I'm 100% sure that the T cells do play a major role. But I was not sure what the first part of the question was.
That was because of this PAUSE study by Harris et al. Published that looked towards the time to relapse after ustekinumab treatment with or without abatacept, and which was negative.
I mean, you need to be very effective, obviously, to have these effects. So you need to get into remission. You have, with the newer treatments, you have a higher chance to achieve that. And if they also switch the epigenetic changes more or not, we don't know. We just don't know yet.
Hervé Bachelet?
Hervé Bachelet from France. Congratulations to all. It's really great talks. A question more for Kerdin. You mentioned the Elan-Fuchs model. In the first paper, in the innate memory related to the keratinocyte stem cells, apparel, in the context of wound healing, and assumingly possibly applying to inflammatory skin disease, including psoriasis, there is a scenario which is T-cell independent, at least in the mouse model. Meaning an innate memory which remains despite the absence of T cells in these animals. Do you rule out that such a scenario where keratinocyte stem cells might be not completely generating a keratinocyte autonomous scenario, but at least being key player, not necessarily embarking the upstream role of the IL-17 secreting cells might be engaged? In other words, that it would be a downstream phenomenon, and that the presence of TRM might be a symptom, a sign, not the key driver. I mean, that's provocative, of course.
Yeah. But tough one, sorry. Really tough question. I don't know. I mean, this is about the chicken and the egg, obviously, in the end. I don't know. What we do know is this innate memory, innate immune cells, now it works. Innate immune cells have a very short half-life usually, so I doubt that they have a very important role in the long run. There are some ILCs and so on which stay longer, but usually it's the progenitor cells which have a longer disease life, and they provide these epigenetic changes. If they move into the skin and actually play a role, I don't know. I have no clue whatsoever. I would assume that it's most likely the T cells which drive the epigenetic changes, and this then feeds back to the T cells again. But in the end, again, this is all very, very early.
Thank you.
I'm having a microphone.
And please identify yourself. I don't see who's next.
Yes, so I'm Julius Babila from Germany. My question goes to Professor Conrad. You showed in one of the slides, it's actually like 2 questions away from me. You showed in one of the slides that the disease memory can be disaggregated into T cell memory and epigenetic memory. or changes. Which arm do you think is significant? And do you think this can change in the course of the disease? Like one arm is more significant in early disease and changing over time in late disease?
I didn't understand the question properly. I'm
So
sorry.
you showed in one of the slides that disease memory can be disaggregated into T cell memory on the one hand and into epigenetic effects or changes. So which of the arms is more significant? That is the first question. And do you think this can change in early disease, like one arm is more significant and the other arm becomes significant in late disease?
I mean, it's a little bit my reply to Hervé before. We just don't know yet, and it's a bit of a question of what comes first and what comes after. And the studies will have to show that, and we're still early on, and it's just Novartis which is now in the position to reply some first questions in that regard. I just don't know. I think it's probably a combination of both, but which is the more important player, I don't know. I would assume it's the T cells, but for the disease modification, I would assume it's probably rather the epigenetic changes. I think that we have a subpopulation of patients we can reverse these changes, and these are the ones which have this long-lasting effect, but in the end, it's just guessing.
Thank you very much.
I think we have time for 2 more quick questions, and then we'll have the break. So 2 more questions. Yeah.
Okay. Hi. First of all, thank you about this enlightening symposium. My question is about paradoxical psoriasis induced by anti-tumor necrosis factor alpha. Any biological explanation for this?
Chris, do you have any opinion on that?
Yes, so the question is about paradoxical psoriasis, with anti-TNFs. Well, I think you're shifting, as I showed you just very briefly, that from the IL-17 drive to an interferon drive, most likely. I think that's what's happening.
Okay, thank you.
Those patients.
Thank you very much. My name is Akiko Arakawa. I'm working in Munich, so together with Professor York Prince. So from our point of view, sorry, it's just my comment. From our point of view, so I think these things can be well understood based on clonal selection theory in basic immunology. So if auto-reactive T cell recognize autoantigen, so they partly, at least some of them, make clonal expansion and enhance their specificity in our body, in the patient's body. And actually, if I could detect many T cell clones only in CD8 T cell in the peripheral blood of a patient, and then I think this clonal expansion occurred at a systemic level, not only in skin region. And then afterwards, autoreactive reactive CD8 T cell can produce IL-17, and I think also interferon gamma. And interferon gamma can induce HLA-CO602 expression and LAP1 expression in psoriasis region, and this can naturally induce or enhance autoantigen expression, presentation and processing. So this we also reported in the last year. So then there are I think, form a small disease circuit in this way. So this is our current theory, current hypothesis, sorry. But then I think how we can interfere the T cell memory, this is the next question. And as we see from...
sorry, but it's extremely difficult to hear up here, so you have to make your question short and specific, because it's difficult.
Yes, a specific question. So I think T cell memory is quite difficult to interfere. So when we see the practice of vaccination, we see how difficult it is to manage the T cell memory. So do you have some idea or some recommendation or future direction for T cell memory research?
Yeah, so I guess the question is towards me. I completely agree. The circulating T cells play a major role, that's without a question. The idea was just that you don't need them for initiating the recurrency. So you have these skin-resident memory T cells which are sufficient to drive this first inflammation and the development of the disease. And afterwards, obviously, there are circulating T cells which then lead to the fully blown recurrency or flare. So completely agree on that. But you don't need the circulating ones to initiate it. Yeah, I mean, the whole memory, obviously, and particularly the work by Elaine Fuchs and her group, and now by Shruti Naik, has completely changed the conception of the disease, and in a lot of diseases, and I think this will open up a completely new field of research, and I think the field is open for you to harvest. So, but you can go in the NG direction about T cells, innate lymphocytes, or stem cells. So, I don't know.
Thank you very much. Any last-minute comments from the speakers? Seems not. I think we should say thank you for excellent presentations to all of you.